Welcome to today's roundtable on prostate cancer. Today we'll be discussing different aspects of prostate cancer with multidisciplinary interaction. I'm Dr. Ulka Vaishampayan. I'm a medical oncologist at University of Michigan. Joining here are some of my friends and colleagues, and I will start the discussion. Prior to that, we'll introduce them, starting with Dr. Phoebe Tsao.
So I'm Dr. Phoebe Tsao. I'm a medical oncologist at the VA Ann Arbor Healthcare System and the University of Michigan.
Dr. Todd Morgan.
I'm Todd Morgan. I'm a urologic oncologist and chief of urologic oncology at the University of Michigan.
Dr. Phillip Palmbos.
Yeah, my name is Phillip Palmbos. I'm a medical oncologist at the University of Michigan.
Dr. Frank Cackowski.
Yeah, thank you. Frank Cackowski. I'm a medical oncologist treating genitourinary malignancies at Karmanos Cancer Center and Wayne State.
And Dr. Bob Dess.
Hi, Bob Dess from University of Michigan. I'm a radiation oncologist focused on clinician and researcher in prostate cancer.
I just wanted to start with introducing a topic of approach towards metastatic disease. And frequently in the urology and radiation oncology world, I imagine you stumble upon metastatic disease. And I just want to start with illustrating this with a case, a 62-year-old, otherwise healthy man who presents with elevated PSA, has a biopsy, has Gleason 7 or so cancer, 4 + 3 = 7, in his prostate biopsy adenocarcinoma. And you do a bone scan, which is showing 3 areas of metastases. Todd, what are you going to offer? This patient is seeing you. You've done the biopsy. How do you approach it?
Thanks. I think the reality actually is that we don't see that patient that often right now, right? Because these patients are mostly getting a PET scan. And not that long ago, we would see a patient like this.
Yes.
And I think we would wonder, are those bone lesions real? Mm. The traditional bone scan, technician bone scan has high rates of false positivity, false negativity as well. But I think a lot of time now we're seeing these in cases where we would not suspect it. And I think regardless, if we see a patient with a likely bone lesion that we think is real, then we're typically not going to offer surgery. That's, we have trials, we're assessing local therapy. SWOG 1802 is a really important one. We think maybe that local therapy might help, but at this point we don't have the data to support it. So that's a patient where we're counseling, surgery is probably not going to be our best option. Let's talk about other treatments. We're talking about systemic therapy. Of course, we're talking about radiation, and I'm sure Bob has something to say about that.
Yeah. I think we're fortunate in Michigan and a lot of places that we get a chance to review these in multidisciplinary clinic, Todd, and I see a lot of patients together. Because you're right, Todd, a lot of these in the old times, 5 years ago, pre-PSMA PET scans, a lot of those we question, is this real or not? It doesn't fit the story. You might have a PSA that isn't all that elevated. You might have a Gleason score that's Gleason 7. And so, but more and more we're getting these patients that are worked up originally with PSMA PET scans. But even those, Todd and I will look very closely at the images themselves and make sure that we're not causing false positives, like an isolated rib lesion, for example. We really have to question, is that an area that's true metastatic disease? And if we have to work with our nuclear medicine colleagues and radiology colleagues, they really can help, tie the story together for us. And then it's sort of a bit of an evolving space, right? A lot of the evidence, certainly with radiation and systemic therapy, are based off of conventional imaging. Mm-hmm. And so the benefits of primary treatment, the benefits of a lot of the old legacy RTOG trials or NRG trials are all based off of patients that clearly would have had metastatic disease in upwards of 30% of disease, either regionally or distantly. Mm-hmm. So we acknowledge those metastases. If they're confirmed to be real, we tell people there's ongoing trials. Stampede 2, the US version is Metanova, that's talking about, do we treat these metastases with radiation in the upfront de novo setting? But the reality is a lot of times we're acting as though, from a radiation perspective, treating the primary prostate tumor, I think, is well supported based off of data. And oftentimes treating as if we weren't seeing those metastases, and then bringing in the medical oncology colleagues. I'm sure all 4 of you are competent and willing to discuss this, but then when do we think about, hormonal therapy, what type and what duration?
But so with those metastases, however, so say that the same guy, you get the PSMA PET scan, and you see the same thing, the same 3 metastases.
Yeah.
Are you guys treating those with radiation, an oligometastatic approach?
So I guess first, terminology. I think we try to be very clear in our notes and our documentation and our communication that those, especially those coming in with PET scan alone, that they're molecularly defined. So the role of primary prostate radiation was sort of defined based off of conventional imaging. So that is our highest level of evidence is treating the primary prostate. And then we have shared decision-making about do we treat those patients with oligometastasis. I find myself treating them more and more frequently in the upfront setting, but we acknowledge that treating those spots is extrapolation from the recurrent setting. And really there's trials that are ongoing that's gonna figure out what are the benefits of treating those in the upfront setting. Sometimes the practical approach is that sort of takes care of itself. If you have an ischial metastasis right next to the prostate, it's pretty easy to treat that as part of a primary prostate plan. So sometimes it becomes a bit of a bigger, less of a deal than we're making it out to be here. But there's no question, I think a lot of patients are asking Todd, like, why can't we do surgery? We can do surgery. And there have been times, right, Todd, that we don't know that those metastases are real for sure. And surgery, in my mind, is an okay thing to discuss for those patients that we don't really know if they're real.
Yeah, it's a great point because in those instances where we're really unsure, one advantage of surgery is we expect the PSA to be 0 afterwards.
That's right.
And if it's not, then we at that point have an answer. But a lot of the time, those lesions that we thought might be cancer probably won't turn out to really be nothing in the end.
And I guess finally, my last thought about, to the point of should we treat or not, whether it's to the primary prostate or whether it's oligometastatic disease with SBRT, we can talk about that throughout the recording, can you do it safely? So I think in areas of gray zone of data, you really have to lean into the low toxicity with a lot of these treatments. And if we think that we're going to put a patient at undue toxicity for whatever reason, they've had radiation before, it's too close to a risky organ, then of course you can certainly lean on advances in systemic therapy as well.
So Frank, it looked like you would have a different approach. Would you approach first with systemic therapy? Is that what you're?
No. Typically, not really that different. So I would say if we think that those are molecular defined metastases or conventional imaging defined metastases, definitely he should get systemic therapy and treatment intensification. So ADT plus a pill. But I am commonly, if there's a few number of oligometastatic sites, discussing with the radiation oncologist about whether they can be treated.
I need strong feelings about the sequence. So.
I mean, I think most of the time we would lead in with a hormonal therapy and follow up with the radiation at some point down the line within a couple weeks to months after the start of hormonal therapy. And I agree with Frank that we would usually combine the primary androgen deprivation therapy with some sort of androgen receptor signaling modifier agent, oral medication. So,
Okay. Are there any prognostic predictive characteristics you would use, Phoebe?
Yeah, it's a good question. I think there's quite a few. I'll answer that, and then I had like a thought about what Bob was saying too. I think we're talking about the patient that was an example. It was like a de novo patient.
Right.
So they're going to get their primary treated, and we know de novo versus recurrent metastatic disease, someone who's had their primary treated either with radiation or surgery, and then the cancer comes back as metastatic disease. That's usually a better prognosis. And then that patient has low volume disease. So volume of disease is another prognostic feature. I think we're learning more and more about the genomics of all of this too. And so we have some hints of that, but it's not really driving our care, up front per se, but it probably will one day, like lower risk genomics versus higher risk genomics. So those are some of the things I think about. But one thought, I think as Bob alluded to, this is like such a data poor space and a lot of trials coming out. And a plug for the VA. The VA is also doing a trial about systemic therapy versus systemic therapy post-radiation to all sites of disease called Starport. But one thought I do have is at least our treatment paradigm for metastatic disease systemically is indefinite therapy. So there is a hope, maybe we'll see what the data shows, if these sites are all radiated, could they go off of their systemic therapy at some point in time? Because to consign a person to lifelong ADT plus a androgen receptor or pathway inhibitor that we'll talk more about definitely has toxicity. So sometimes I'm hoping that there will be more strategies that will allow people to have time off treatment too.
So is there a certain duration you have in mind?
I mean, I don't think that's been defined, right? I tend to aim for 2 years in practice based on extrapolation from some other data. But that's not really known, and it's also a shared decision-making with the patient who's in front of us and how well they tolerate the therapies, so.